All right. Well, I know we'll have some folks probably joining us as we get going, but I think we'll get started because the first part is me sharing some comments. So welcome everybody to our Q&A with Dr. Michael Osterholm. This is an event that is put on by the Minnesota Public Health Association Membership Committee. Hopefully you're all familiar with MPHA as members, but the mission of MPHA is to create a healthier Minnesota through effective public health practice and engaged citizens. My name is Ellen Solaris. My pronouns are she and her, and I am one of the co-chairs for the membership committee, along with Claire Fleming, who is waving right now if you can see. And I also want to note that Mary Grand, who is the executive director of the Public Health Association, is also here. And we will start, as we start all MPHA events, with our ancestral land acknowledgement. All right. So if you've been to our events, you know that this is a statement that was developed by our Health Equity Committee in partnership with a number of other folks. All right. So we ask that you take a moment to honor and acknowledge that we are on the ancestral homelands of the Dakota and Anishinaabe. Indigenous people have had a long-standing history and connection to the land since time immemorial and are the original stewards of lands and waters. Many American Indians were forcibly exiled from their lands because of aggressive and persistent settler colonialism and U.S. governmental policies, but they persevered. We make this acknowledgement to honor the Dakota and Anishinaabe people, ancestors and descendants, as well as the land itself. We have a couple housekeeping items. You'll notice that your microphones are muted. Please stay muted for the entirety of this presentation so we can cut down on background noise. It's up to you whether or not you want to have your camera on for video. As Claire mentioned, we will be recording this event. We're going to have you put questions and comments into the chat. If you submitted questions ahead of time, we do have those, and we're going to try and get to all of them. We're going to have some comments from Dr. Osterholm for about 15 minutes until 1 o'clock, and then we're going to open it up for some more questions. And now, without further ado, I'm going to provide a bio for someone that I think lots of people are familiar with because he's been making a lot of the rounds and sharing a lot of really important information during the COVID-19 pandemic. So Dr. Osterholm is Regents Professor, McKnight Presidential Endowed Chair in Public Health, the Director of the Center for Infectious Disease Research and Policy, Distinguished Teaching Professor in the Division of Environmental Health Sciences in the School of Public Health, a Professor in the Technological Leadership Institute, College of Science and Engineering, and an Adjunct Professor in the Medical School, all at the University of Minnesota. He is also a member of the National Academy of Medicine and the Council of Foreign Relations. In July 2008, he was named to the University of Minnesota Academic Health Center's Academy of Excellence in Health Research. Dr. Osterholm is an internationally recognized expert in many, many things, including infectious disease epidemiology, disease surveillance, health communications, social media, foodborne, HIV/AIDS, STDs, influenza, public health preparedness, vaccines. He is also the author of more than 300 papers and abstracts, including 20 book chapters, and a very excellent and helpful podcast, if you have not been listening to it, which can be found on Spotify and the CDRAP website. So let's all join together in some virtual, and I'll do real applause.
Thank you.
Yeah.
Well, thank you for that very kind introduction. See, that's what happens if you work for 322 years. You can do things, okay? So that's a large part of it. Actually, thank you all for being here today, and I appreciate very, very much this. This is a bit of a factoid for which it probably is of no significance to any of you, but actually the very, very first talk I ever gave as a student or as an employee at the Minnesota Department of Health back in the fall of 1975 was to an MPHA meeting. So from a standpoint, it's kind of coming home again after all these years. The difference, I think, is right now is that I have spent about 70% of my career total since last December. It's been all time consuming. I can't kind of remember a time before COVID-19. And so that gives you some sense of where we're at. Most days I have no idea what day of the week it is. I can't tell you for certain what the date is. I can't tell you in some days even what time it is. It's kind of one of those issues right now with this disease. Our center became very involved with this issue in December of last year. The last week we recognized something was going on unusual in China. We have an extensive network around the world at CIDRAP to capture information and to share it through particularly our news team, but also to monitor it in terms of any kind of policy issues or work that we can do. We recognized in the first week of January that this was not going to be influenza and made the assumption it would be a coronavirus, but more in the lines of SARS and MERS. I'd been very involved with both of those issues back in 2003 when SARS hit. I was still splitting time after post 9/11 as a special assistant to Tommy Thompson, where I split half my time at HHS and half the time at the CIDRAP. And so I was very involved with the SARS experience. And then again in 2012, when MERS emerged on the Arabian Peninsula, I was involved with that, served as an advisor to the royal family in Abu Dhabi, and actually was involved with the investigation of a large MERS outbreak that occurred at Samsung Medical Center in Seoul, Korea, when an individual came back from the Arabian Peninsula with the virus. In both of those cases, the infectiousness status of a patient was really quite minimal until about the 5th or 6th day of in their illness. And so once we understood that we could quickly identify such patients and actually get them isolated, it became a relatively easier job of trying to stop the epidemics. And of course, we wanted to eliminate the animal reservoir. We were able to do that with SARS when we found in the markets of the Guangdong province what the animal was, got it out of there. A little bit more difficult in the Arabian Peninsula since camels are the reservoir for that. You're not going to put down 1.7 million camels. Probably one of the most memorable days of my career was standing before His Royal Highness's camel farm in Abu Dhabi, and I saw 3 separate camels. Each were valued over $40 million a piece. Secretariat didn't bring that. So we knew that the camels were not going to be lost quickly there. So, but in this case, what we thought was happening in China was the fact that, well, this is going to be another SARS, MERS-like situation. We'll get it under control by identifying cases quickly. By January 10th, we knew that that wasn't the case at all. We were seeing what was considerable person-to-person transmission that couldn't be accounted for in China by this late onset transmission. And, at that point, people were suggesting, that, it was just yet unrecognized that there was occurring later in the infection status. And by January 20th, we were absolutely convinced. I put out a statement from CIDRAP on January 20th saying this would be another pandemic. It was going to be significant and we had to get ready. Unfortunately, as you know, that didn't happen for almost 2 months before the world declared this a pandemic and really got on with the business of trying to deal with it. From a historic perspective, I only point this out because it's a very, very important marker for understanding where we're at today, is that we then saw basically the house on fire events around the world, where Wuhan in China and the Hubei province was quickly brought under control by the Chinese means of distancing, which their enforcement capacity is unique, to say the least. We saw a number of places around the world catch on fire, most notably here in the United States, New York City, and the metropolitan area there, as well as some major outbreaks in Chicago, Detroit, New Orleans, and Seattle. But they were basically brought under control in those other cities, including New York City, by late in April, early May in a way that was, at that point, I think everyone felt comfortable that this was going to be okay. But remember, the cases still were occurring in the rest of the country. They were spreading more and more. And we had the largest number of cases reported in mid-May at 32,000 cases a day. And then we got it down by Memorial Day to 22,000 cases a day after what was considered a lockdown of about 8 weeks, which we really didn't lock down. We did a slowdown. There's a business group that actually helps define what we consider essential workers in Minnesota. About 38% of our population were considered essential workers by that definition, yet over 70% were declared essential workers by the governor. So we saw some slowdown, but we still had a lot of activity going on, other than the bars and restaurants being shut down some. At that point in Memorial Day, we know the combination of events. We got tired of the pandemic and developed an acute case of pandemic fatigue. The George Floyd situation, the horrible tragedy of that unfolded, and the number of protests bringing lots of people out. And then, of course, just the fact that it was summer weather in Minnesota, and we do what we do in Minnesota in summer weather. But this was true around the country. Everyone kind of came out. And we gave up on any kind of real control. Meanwhile, other countries of the world that had been houses on fire continued to work hard. They drove their case numbers down literally to a level of less than one new case per 100,000 population per day, at least 8 to 10 times lower than we ever got close to. And as a result, you saw what happened in the United States. Over the course of the summer, we saw a very rapid escalation of cases as we reopened our economy, as it was often termed. We got up into the mid 60,000 number of cases per day in late July. And with, again, a great deal of attention and efforts made at prevention, we saw that by the end of July, early August, these case numbers started to come down, particularly in the most hard-hit states. But now we've leveled off roughly at the low 50s to mid 50s in terms of new cases per day. When I say 50s, I'm talking about thousands. Imagine that's still 20,000 times more cases than we had in New York when it was on fire in April, and we thought that was an incredible disaster. The cases dying went from about 2,200 at its height during the mid-April time period down to now to 1,000, 1,200 a day that we're seeing in the United States, so 1,000 less, but that's leveled off. It's now plateaued, and new cases have plateaued. And I think, some will say, well, this is good news. Well, this is where we were before. So you get a spike, a little bit of a drop, a plateau, a spike, a little bit of a drop, a plateau. And I think what's going to happen is shortly after Labor Day, we're going to see a dramatic increase in cases in this country, largely tied to enhanced transmission in colleges, universities, and high schools. It is going to take us to a whole new peak, far higher than what we saw with the 65,000 cases. I hope I'm wrong. I think that surely is a real possibility. And we're going to see continued transmission then from these young adults and adolescents into the general population, older individuals who are going to be at higher risk for severe disease, and we're going to be really challenged. At this point, I don't think we have the political will in this country to do what we need to do. Last weekend, Neel Kashkari, the Federal Reserve Bank president here in Minneapolis, and I wrote a piece in the New York Times calling for another, in a sense, lockdown, but with full compensation for everyone, so that everyone was held whole, whether it's individuals, small businesses, city or state governments, et cetera, because of the fact that with the pandemic, our savings rate in this country had increased dramatically from less than 8% to over 20%. And we could actually finance the entire support for this kind of effort out of US dollars as an investment in the US itself. So I don't think there's any appetite for it at this point, however, and if not, we're just going to continue to see us bleed to death, literally and figuratively, as a result of increasing cases and what will turn out to be economically a much worse situation than if we took our medicine now and shut down. What's our long-term goal? Well, at this point, across the board nationally, we're at about 8 to 10% of the population is now immune to this virus. in the sense that they have had infection and have recovered. When I say immune, we surely understand that there's questions about what is immunity, durable immunity. But basically, the bottom line is 8 to 10% of the country has been infected, higher in some of the high-risk areas where they, in a sense, have been a house on fire. And if you go back and look at this then and realize, wow, all the pain, suffering, death, and economic disruption for 8 to 10%, and for us to get to what would be considered herd immunity is likely to be 50 to 70%. There's lots of discussions about that today. I think that's still really the viable number. And with herd immunity, remember, you don't have a case of stop. They just slow down in terms of the number of new transmissions. And so I think at this point, we are a long, long ways to go to get out of this pandemic. With the question of durable immunity comes the issue about vaccines. Can we get long-term protection? We don't know that. With other coronaviruses, it's difficult to do that, if not impossible. So we are working on vaccines. Vaccines will be forthcoming. We can get into the questions and answer that if you want, but there's a tremendous number of challenges about vaccines, how long they'll protect, what are the issues in terms of safety and so forth. And surely that's going to be a big challenge. That would be ideal if we could develop our quote unquote herd immunity from vaccines as opposed to having to do natural disease and all the consequences of that. So with that, I will end here and open it up for questions, comments. I welcome any of your thoughts. I will just give you two disclosures that I think that's very important. Number one is that I probably know less about this disease today than I did 3 months ago. The more we learn, I think the more challenged we are to understand what we know and don't know. And the second thing is, though, however, one of the few benefits of growing old is that I'm more vulnerable to learning now than I've ever been in my life. So I'm wide open to your insights and thoughts, and look forward to taking your questions. So with that, I'll turn it back over to you and we can go from there.
Thank you. Well, you addressed some of the questions that were submitted ahead of time, but we still have lots of questions because, like you said, we're all in a place of immense learning every single day about this pandemic. So I think I'll start with a question that relates to what you're talking about around political will. Where do you think we could have done better to bring everyone together to cooperate instead of politicizing decisions that are being made around this pandemic? In your opinion, has it been a lack of national leadership, or are there other missteps that have been made, keeping in mind that hindsight is 20/20?
Yeah. Well, first of all, I have in my career served in the last 5 presidential administrations. Even in this one, I was a science envoy for the State Department for a year, 2 years ago, and traveled around the world on behalf of the State Department working on pandemic preparedness, ironically. And in that regard, and also I served as a state epidemiologist, as you know, at the Minnesota Department of Health, and I worked for 2 Democratic governors, 2 Republican governors, and 1 independent governor during that time period. And, I really left my partisan politics at the door. My job is to provide the best and most important scientific information I can, as factually as I can. And so some people find this less than pleasing, but I have refused to get into the partisan mix and tried to keep the facts, and let either side, however, use them as such. And so let me just say in that regard, there has been a tremendous amount of questioning about the leadership we've had at all levels in terms of how we bring together our country. But that's an issue that's far beyond that of just COVID-19. Any of us in public health understand the challenges we've had recently, whether it's the anti-science movement, vaccines, climate change, any number of things. And we have watched this issue in particular really take the worst of the worst and make it even worse. And, I actually had a history professor from a major university say to me last week in a conversation that for the first time in his life, he understood what it must have been like for a family, a father and a mother, to send their boys off to war, half fighting for the North and half fighting for the South. Because the divisions that we've seen, even in our families, over issues related to this pandemic, and the political issues of believing it's everything from a hoax, to the fact that we've, the sense that it's been a very counterproductive leadership exercise. So we have a challenge. Long after this pandemic's over with, we're going to have to figure out how, as a nation, can we heal? Can we come back together? Can we, in a sense, find the power of science and believe it, and not assume that there are alternative facts, or that there are, in effect, the what I would call the ongoing line that's anti-science. And so it's a challenge. That has made this much, much more complicated. The fact that so many issues have broken down into one side or the other. And I have never, I've been involved with a lot of critical and complicated and controversial issues over my career, and none like I've seen here. For the first time in my life, I found myself in the middle between what might be considered a far right or a far left view, or either way. And being in the middle, I was the extremist. Good example is masking. I think that the issue around, do I mask or do I not mask, has been a terribly unfortunate situation, because we've had those who just are absolutely refuse to mask and consider it a political issue of their personal rights, when there may be some benefit to masking that we should capture. A layered on effect, clearly just that. But you should use everything you can in a pandemic like this. On the other side, you have people who have far stretched the accuracy and the truth about what we know about how well face cloth coverings can prevent transmission. And we are short on data to show that with these kinds of things. And the studies that have come out have been fraught with error, have had poor study designs. And, that's not a reason not to use face cloth coverings, because there very well may be protection. But the fact that we can't have a nuanced discussion of that in a way that helps people protect themselves. My message is wear a mask, but distance is still the most important thing you can do. And the fact that that one issue got caught up into such rancorous politics is unfortunate. And I can go through other ones. The school openings are another one, the same kind of situation. So I have to say that we're in a unique time, and it's not just in this country. This is happening around the world. But our country surely, unfortunately, has been the global leader in dealing with this issue in a most unfortunate way.
There's a lot of nuanced information, and a lot of information that is not nuanced that's being shared through like an uncontrollable number of platforms, right? Amongst like communities and populations that may not have that nuanced understanding to be informed consumers of health information or research.
In fact, you mentioned earlier about my weekly podcast. The title of my weekly podcast this week is Message Chaos.
Yes. We had a couple questions related to what country or countries do you think serve as best models for the US to use in addressing COVID-19 at this point, and your thoughts about Sweden.
Yeah. Well, first of all, let me just say that, the rest of the world, much of it taught us what could be done last March, April, and May in terms of driving down the case numbers. We put out originally a document that said, we don't know how the virus is going to move from April into the rest of the population. Could it look like a flu pandemic that would truly come in waves? A first wave that then disappears all on its own, comes back several months later? Could this be, because it is not an influenza virus, a coronavirus pandemic? What might that look like? Could it be kind of a slow, constant burn? Could it be a big forest fire that just burns every piece of human wood it can find? And we've come upon the third one, really is the method. It's just moving. And so that when we look at this issue and say, okay, so where are we at and where are we going with this situation now? I think that what we've learned is that basically this will just keep infecting people as long and as much as it can. And the countries that basically dropped their transmission levels down and kept their lockdowns in place to get to below 1 case per 100,000 per population per day, really were the ones that also literally brought this to a screeching halt. And we don't even have to go outside the United States. Look at the state of New York. This has been a remarkable comment to say this island, which at one time was truly the house on fire, has now had 12 consecutive weeks of very low numbers, less than 1% positivity rate. And while their economy is not fully opened, there's still challenges there. They could blow up tomorrow. They've done a great job. And so what we didn't learn as a country was what these other countries did and then taught us. But now, unfortunately, we're teaching other countries something that is really sad. If you look around the world right now, we've seen an emergence over the past 3 to 4 weeks of cases in Europe and Asia, where what's happened is they're letting up. A good example, I was just did a program yesterday in Ireland online with one of their leading investigators there. And they're now reporting, which had been single digit positivity in their testing, 22 to 23% positives, all with the opening of the bars and the restaurants and letting people back out in kind of this unrestricted way. And the lesson that we should have taught them is, once this gets away from you, again, unless you keep the brakes on, pump a little bit here, let off a little bit, pump here, which is what New York has done, it's going to come back. And so from that perspective, I can't say there's a country right now that I can look at and say has done it right. Even New Zealand, a country I love dearly, been there and enjoy New Zealand more than other places in the earth except Minnesota. And, look what's happened in the past 2 weeks there. They've uncovered an ongoing outbreak where their border security, in the sense of looking at people coming into the island with the virus, obviously didn't work. And the virus is now transmitted inside of New Zealand. They have to go back and, in a sense, start all over again to try to get them to be virus free. So I can't say there is one country. I think all of us teach each other something. We've taught good lessons and bad lessons to each other. As far as Sweden, that country that I've had it said to me once, I've had it said to me 10 times, well, they know how to do it. Look what they're doing. Early on, they were supposed going to get to herd immunity. It turned out to be a disaster. As most people know, their death rate was higher than any other place around in terms of the Scandinavian countries, all kinds of things. Well, now for the last 6 to 7 weeks, they've had pretty flat numbers. And my response to that is, it's not because of anything they did, it's a time and place. Remember last spring when the state of California said, oh, look at, we're doing really well here. We know what to do here. We don't have mass transit. We don't have all these people working in big buildings downtown LA. And everybody thought, well, that must be the answer. Or that's why they're not seeing any cases. And then what happened? Come July and August, they were a total house on fire and now lead the nation in number of cases and deaths. And so I think that Sweden, give them another 6, 8, 10, 12 weeks. I wish not for it to happen, but I'm quite convinced it will. They'll be on fire again. This is what this virus does if you don't keep your foot on the brake in some manner. And so Sweden to me is just an experience that, again, will come back one day and see how they didn't do it the way that some of us wish they had.
Yeah. We have many questions related to the vaccine, which you addressed a little before. So the questions are related to, your views around potential efficacy, whether we would need a new vaccine each year, like influenza, and kind of some thoughts about how to best handle distribution when we get to that point.
Well, first of all, let me just say that, again, this is a work in process and progress with vaccines. We have not had a successful vaccine for a coronavirus in humans before. MERS and SARS were not. And there have been real challenges and questions raised about the durability of immunity with any kind of infection or a vaccine with the coronavirus. And so these are questions that won't be answered for some time to come. What is the durability? How long might it last? And how protective will it be? You've already heard the FDA, the NIH, now there's more or less forecasting, if it's anything over 50%, we could very well license it, and 50% protection meaning. And again, think about that from the standpoint of what might be the subgroups that'll be important there. Well, it'd be great if you had a vaccine that protected young, healthy adults that otherwise still didn't get sick, but maybe slowed down their ability to transmit the virus. But what we really want to hit are those people at highest risk of serious, life-threatening disease and death. And as we know with influenza, older people, people with underlying health concerns, comorbidities, people with higher body mass indexes, all perform much more poorly in terms of influenza vaccine protection. And so we don't know if that's not going to happen here too. That's something we're still just going to have to wait and see. And I'm convinced there will be vaccines that will make it to the market. You've already heard about the Russian experience last week, and I think that's a very unfortunate situation where they're putting a vaccine out there long before they have effectiveness and safety data to be used to help the public understand it. I worry that if we don't handle this correctly in terms of having the body of data that looks at both safety and effectiveness, that we could pay a price one day if something does happen and we skipped over some of the safety steps. That's why, as much as we want this vaccine as soon as possible, a number of my colleagues and I are very committed to being very public about whether we support the use of this vaccine or not. I've every reason to believe at this point the FDA will do their job. The European regulators will do their jobs. EMA, which is the FDA of Europe, will do that. And that we will, in fact, have vaccines that have been thoroughly vetted from a safety standpoint. And then, promote them the best we can. If that doesn't happen, this will be a very, very difficult situation, because I would never imagine a public health community speaking out against the use of a vaccine, short of the fact that we already had demonstrated that it was some challenge with it in terms of safety. Here, we need the adequate data to be able to be assured that every reasonable step has been taken to give us a safe and effective vaccine. Now, having said that, we can't wait 5 years for that vaccine to happen. Which would be ideal. So we're going to have to make some hard choices about what it is that we find acceptable and how we support it. In terms of distribution, we're still waiting to find out about that. Just this morning, the administration announced that McKesson, which is the distributor and provider for the VFC vaccines in this country, has been named as the primary oversight organization for distribution of this vaccine. There's still a lot of questions about who is at the top of the list for priority. That's being looked at by several different groups, for which it's still unclear what their overall recommendations are going to be, and who decides in the end what will be considered the actual prioritization. We also have to look at the rest of the world. There are 8 billion plus people that want these vaccines right now. There are surely going to be production in a number of different countries, but I think it's important that we understand we do have a fundamental obligation as a nation like ours to help and assist the low and middle income countries with this. This can't be a vaccine that just goes to high income countries. That would be a terribly unfortunate situation. So equity is going to be huge, even in this country. How do we quickly get the vaccine to those most at risk of serious disease? And it might not be the obvious choices of who will get it first. We need to look at the risk groups that we believe will benefit the most from these vaccines.
Mm-hmm. Yeah, and how we communicate about this information is extremely important, because there's a lack of unipolarity around vaccines in general.
Communication is going to be huge. And, that again is, I think, tell people what you know and what you don't know. I worried today, I think we have had an epidemic of experts in this country, all who've come forward around this area. And I will put myself in the category of having to be accountable every day for the comments I make. What do I know and not know? How do I know it? I'm not an expert virologist. I'm not an expert in econ. I'm not an expert in a lot of things. So how do I know what I know, and how can I comment on that? And I think we need to hold everybody accountable to that same thing, including people who will make comments about vaccines.
Mm-hmm. Yeah. Another area, it seems like there's been quite a bit of differing information about is the antibody test. Could you speak a little bit about the antibody test and their potential value or not?
Right. Well, I think the antibody test is one that, first of all, which test we're talking about, one where we actually just do total antibody, or where we actually have neutralizing antibody determinations, which really give us a much different level of assuredness that they really are true antibodies for this particular virus infection. Early on, that wasn't available. It was just general antibody against this, and there was real challenges about the sensitivity and specificity of that, notably that in a very low prevalent population, such as 5% positive, over half of all the positive test results coming back could be false positives, which surely doesn't help anybody know, have I been infected, and do I have some hope for being protected? That's changing to the extent that we now have better antibody tests out there. But still, we don't know what kind of protection that means. Does it mean you're protected or not? That's why CDC, at the end of last week, put out a statement basically saying you don't need to get retested again if you've been infected for the next 3 months after that, because you're likely still going to be potentially shedding some of the viral debris that might give you a positive PCR. Doesn't mean you're infected, and some sense that there may be some immunity from that. Now they've walked that back a bit about, do I mean they're immune or not? But I think most everyone assumes that at least in those first 3 months, you probably are protected. So knowing you're antibody positive would be helpful in that regard.
I've seen some information about kind of mass, cheaper, faster, but less sensitive COVID-19 test. What are your thoughts about the pros and cons of a testing approach like that?
Well, next week I'm actually going to talk, or this week actually, and next podcast, I'm actually going to get into that in some detail. There are these new tests coming out that are saliva-based samples, which still use PCR for testing. Some are antigen-related testing, which is like point of care. And it's a nightmare out there right now, in terms of what they mean or not mean. For example, a new test just came out from Yale yesterday, or on Saturday, approved by the FDA, for sampling with saliva that then still goes to the standard laboratory and gets run by PCR. This test probably has a reduction in sensitivity by 5 to 7%. So from a clinical lab standpoint and an ill patient in a healthcare facility, this is not the test you want to use. You want to know that you have the most sensitive test you can. On the other hand, for screening, if you're out there and every day people are coming to work and you want to screen your employees, and that's a decision that's made, this test might be very satisfactory. So the challenge we've had is, how do you match up the right test for what you need? And we actually put out a document from our center I'd encourage people to go take a look at. It's under the viewpoint section of our coronavirus resource center, and it's all about testing. And it really lays out the concept of smart testing. You want the right person tested with the right test at the right time for the right result to have the right outcome. And so a test that comes back 8 days later, that's not smart testing. A test that lacks sensitivity when you really need to know for certain, am I positive or not, like in a clinical setting, that's not a smart test. So we could go through a number of those things. So I'd refer you back to that document. I think it still stands the test of time, and it really does lay out the challenges we have with these different test methods. The other thing I have a problem with is we seem to be having a debate in that right now about how many tests are available. Meaning, if you don't have 25 million tests over this time period, you're failing if you have less. And, that's an unfortunate discussion, because with smart testing, a lot of the testing that's going on right now wouldn't happen. And people will say, no, everybody should be tested every day. Well, how are you prepared to handle that? What are you going to do with it? What difference does it make if, in fact, someone is not going to use that? I worry, for example, if I could test every day, every morning, I get up, I take a test, and I'm negative. Well, after a few days to weeks of that, pretty soon, you know what? It reconfirms from everything I'm doing is all correct. I'm going to the bars, but I'm not infected yet. And it supports that behavior. And we've seen that with other examples in public health. And so I would not want that to be the case, because one day that person will become positive and then it's too late. The test didn't help you get there. The same thing is true. Is a test going to result in action that is going to make a difference, not just clinically, but also from a risk standpoint? When you are an essential worker, a single mom with 3 kids, and you're living with your mother in a 2-bedroom apartment, and if you don't go to work, you don't get paid. If you don't get paid, you basically can't afford that apartment. And then that essential worker becomes infected and you're going to tell her to basically isolate herself. How's she going to isolate herself? What is she going to do? And so you got to also have the kind of follow-up programs that support testing being done, the test results, what are you going to do with them, how are you going to deal with them to try to minimize transmission. And, we've only done a so-so job of that in this country. So it's easy to tell everybody, go test our way out of this outbreak, this pandemic. Test, test, test. That is really the wrong mantra. We need to get away from testing to smart testing and making sure that what we're doing, how we're using it is effective, making a difference, and available.
Yeah. The Minnesota Public Health Association advocates for investments in public health infrastructure funding on a state level and sometimes a federal level as well. I'm wondering if you could speak some about what types of public health funding do you recommend we as an association or individual members prioritize? Is it really support for case investigation and contact tracing, technical assistance for workplaces, research, whole plethora? Where do you think there could potentially be the best investment for public health funding?
Well, first of all, let me just answer this the most simple way I can. Yes, 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 and yes. Okay.
If only it worked that way, right?
Yeah, right, exactly. No. I think that the challenge here is that public health's under fire. Last week in my podcast, I dedicated it to the public health workers of the world, and particularly right here in this country, where we've had so many fired or have left their senior jobs just since April because of COVID issues and the abuse and the kinds of challenges they faced. And so, public health has never been under more fire. There are some of us who, because of what we do, have received all kinds of threats, very vile communications on a regular basis from the public. This is a challenge to be in public health today. And I think that in that regard, the first thing we want to do is make sure we have a workforce. And as you know, we've had a tremendous reduction in number of public health positions over the last 10 years in this country. And that by itself is a huge challenge. For the first time, I hope people are really getting their eyes wide open around the benefit and the what I would call essential community service that public health plays in our lives. And this pandemic should give them all the ammunition they need or have to do something about it. Now, having said that, it's not atypical when a crisis like this happens. We're also going to go into very austere budget times. We're in deep trouble. We know that state agencies are going to be in trouble, higher ed's in trouble, just any number of areas right now because of these budget deficits are going to be in trouble. It's going to be a hard time thinking about trying to quote unquote shore up things. But I think that's when we have to make our arguments now. I don't shy away from the fact that we got really severe budget constraints, but at the same time, it's like an insurance policy. When's the last time any of you bought an insurance policy for a house or a car with the intention you couldn't wait to use it? That's not at all what you do. And I think we have to convince our country, our state, our local leaders why public health is so important. So in that regard, I think public health has this job cut out for it to help it make the argument why it is so important and what we do in our communities. And, I think if you look at COVID-19, I have said this from the very beginning. When this pandemic is really done and gone, or hopefully it will be someday, there won't be blue-colored states or red-colored states. There'll be COVID-colored states. There'll be no red and blue counties. It'll be COVID-colored counties. And what we need to do is help people understand that. And that's why we're here. I understood early on in April when the quote-unquote economic lockdowns were occurring, the distancing issues around the state, there were people in many counties saying, why are we doing this in my county? I don't even know anybody who's been infected. But look what's happened since then. Some of the most dynamic transmissions occurred in greater Minnesota. Not uniformly, I agree, but I think this is a huge challenge. So one of the other things we have to make the case for is that this is a statewide effort that needs to be done. Finally, let me just say, there is absolutely no question about public health as the basis for addressing racial disparities. I think that it's a huge issue. and it should be front and center in any of our public health programs. COVID-19 is opening up every dark, horrible box that we could imagine related to health disparities and race. And so I think from that standpoint, we also have to do a much, much better job of putting forward what can we help do about that? What is it that we can do? You know, what are the underlying issues there? And I think this should be one of public health's most important efforts going forward, because as you improve the population health of our Black, brown, indigenous populations, we are going to improve the health of the entire community, and that's going to be important.
Mm-hmm. When we as individuals or as an association as a whole, right? Because a wonderful thing about MPHA is we have some collective power, right, to come up with our messages and our voice and push together. What information or approaches do you think will work best moving forward to increase understanding of the importance of COVID-19 prevention on policy in the general public? Is it a harm reduction approach? You know, is it a harm reduction approach? Is it something else?
Well, I think the first thing is it has to be a policy of tolerance and kindness. Mm-hmm. That may sound counterintuitive.
No, I love that. It makes sense to me.
But it's one where we are going to live in a world right now where there will be massive divides between people. And at that point, if someone tries to be the right voice, the only voice, mm-hmm. it will only drive things further into the ground. And so that doesn't mean that we just shy away from defending the basic tenets of public health. But it also means that, you know, is this the way to win a battle? You know, I've often said in some of the cases I'm involved with right now with COVID-19, I feel like I'm in a debate with 2,000 really tired and angry 2-year-olds, you know, and I'm never going to win a debate there. Yeah. Don't even try. But try to understand, why is this happening? What's the underlying cause of it? And how do we get people to move together? Because in the end, I believe that if the building is on fire and everyone's trying to get out, it won't matter what your political ideology, what it is that is going on inside of your head about public health. You will try to get out of the building together. And so what we need to do is understand, how do we try to start pulling people together? And public health is just a part of the microcosm and the macrocosm of life right now. And so I think that's the first thing. I've said that about education over and over again. Some of you have listened to my podcast. This is a COVID year. It's a do-over year. Do not expect us to have an education year this year like we did 2 years ago, because we won't. We're not going to. And if we make that our goal, we're going to fail miserably. So what do we do in this year? We do the best we can. We try to accommodate teachers. We try to accommodate faculty of higher institutions, education institutions. We try to accommodate parents, grandparents. We accommodate the staffs of these schools and colleges. And I think that by doing that, we'll get through it. Just like what they did when Katrina hit Louisiana. They had a do-over year for their education because their education system just got whacked out of service. And if we come in with more kindness and consideration, I think we will get through it more. Now, that doesn't mean you let kids who are vulnerable, who need emotional and mental support, who need safety issues, who need their foods, we got to take care of them. We got to make that our goal, is to reach out to those kids first and foremost. And if the rest of the kids get some benefit out of it, hey, that's great. But, you know, if we just took the moment to back off and to allow ourselves the opportunity to make mistakes, to not accomplish what we thought we could, that I think will help everyone. And this is what public health needs to do right now. You can both be bold and at the same time be humble. And I think that that's what we need to do right now to try to get us through this, because I see this situation only going more and more worse. I think it's going to get to be much more painful as we get into the months ahead. The case numbers, the situations are going to become more difficult. So, you know, right now in Minnesota, look at the divide in some communities. You know, if you were to wear a mask in some communities, they would assume you're going to rob the bank. In other communities, if you didn't wear the mask, they would assume that you didn't care and you didn't mind if you killed people. I mean, this is where we have to try to draw together people and move forward. And, you know, I've been around far too long, 45 years in this business. I'm not naive, you know, I've seen it all, but I've never also seen a time like this where I think public health can help serve as that vehicle for what do we know, what do we don't know, how do we help people, how do we help the most disadvantaged, and what do we do to get them through this?
Thinking, you know, long term in the future, right? How do we
At my
kind of
age,
stop?
you know, long term may not be that long. So you may want to address this to somebody else.
I think you probably have advice for the long term. You know, what can we do to stop kind of this situation or history from repeating itself over and over again related to infectious disease pandemics?
Well, we all need to figure out when this is all done, the first position we're all going to want to go to is, boy, I'm glad that's done. Let's move on. You know, I liken it more to a 747 going down that has 6,272 black boxes on board, and we got to figure out every one of them. What happened, why, and what we're going to do to make sure that doesn't happen again. You know, I think that that's going to be really important to do that self-reflection, to call a spade a spade. You know, we have to do that to figure out how it happened. I think it's known to some of you at least. You know, I'm going to be writing another book after this is over with. I've already signed with my publisher to do one just on this very issue of what lessons should we have learned, could we have learned, and we need to learn for the future, because we're not done. Influenza pandemic could happen tomorrow. And, you know, when people say how bad this one is, this is bad, trust me, but this is not the big one. The big one would be if it were another 1918 like pandemic, where the number of deaths is dramatically increased in those 18 to 30. That would really cut at our workforce. It would cut at our very society's sense of who and what we are. And so we have to be prepared in a way that we weren't for this one. And so we need to, public health needs to be committed to just about when you're really tired, you're all done having dealt with this one, get back up, get back to work, and figure out how do we help society understand, you know, if you did this, and this, and that, plus maybe this, boy, think how much better prepared we could be for the next one, because Mother Nature is going to keep throwing us curveballs. We are not in control. The bugs were here before us. They're here while we're here, and the bugs are going to be here after we're gone. And what we need to understand is, therefore, we need to be prepared. And it's just that concept by itself is going to be really important.
Yeah, and I think you've really highlighted all of the work we all need to do, right, as individuals, as members of immediate communities, in our workplaces and our families, you know, nationally. And it's been really helpful. Thank you. We have just a couple minutes left. Do you have any final thoughts or questions for the group that you'd like to share?
No, I mean, I think right now I can't say it enough. I've already said it, and I don't want to appear to be, you know, beating it into the ground. But I think right now, if there was ever a time for us to take a new tack to how we do our work, it's now. I mean, I never went to school, and I never in all the years at the MDH or any other place did ever it come up about one of my job responsibilities was kindness. And I think that, you know, right now we need that so badly. That's part of public health. That's part of the mental health of what we're going through right now. Find ways to be kind. And I think that's what people are looking for right now. You know, I can't say enough about how important that will be in helping to get our message across in terms of helping people understand what we need to do and why. And so that isn't a remote concept. It isn't. I can tell you on the front lines right now, that's what people are looking for. Then the message becomes easier to share with them. When you come in with it, not as damn you or what's wrong with you or what, but rather, you know, start out with that. And I think we're going to get farther along. The other thing I would just say is we are going to get through this. We're going to get through it. And we have to just keep remembering that. But what's going to happen is 20, 30, and 40 years from now, when our great-grandchildren are reading about the pandemic of 2020, like you and I have read about the pandemic of 1918, they're going to look back and say, geez, what were great-grandpa and grandma thinking about? What was going on back then? And I think one of the things that we should all measure our activities by how would I want my great grandkids to remember what we as a society did? And so I think also right now, that's where we have to stand up. I've pointed out this issue about the racial disparity piece. We cannot let that go unaddressed. You know, I think that's a huge challenge. And so to me, I would just say, you know, more now than ever, public health is desperately needed. Now more than ever, our messaging has to be not just on the facts, but also on the sense of who we are as a society. And if not, I fear that we're just going to drive ourselves further and further apart. And on top of an election, on top of major budget deficits, on top of healthcare facilities that are overstretched beyond any imagination, beyond the fact that as a global power, we surely have a very different understanding and role of that today than we did even just a few years ago. These are all things that public health is all about. And so just more, we need you more now than ever. Public health has never been more needed than it is at this moment.
Thank you so much.
Thank you.
I would recommend everyone to check out the podcast. No, really, I wasn't prompted to do any promotion. I genuinely find it very helpful and reassuring, even when the information that you're providing is not, you know, like that we're in a really serious situation. I really appreciate it. And I'm sure I speak for other folks when I say it is a pleasure in being able to be informed by you,
Thank you.
About things that are really complicated, and you do it with such grace, recognizing the complexity of the situations, like you said. Thanks. So I want to say, thank you.
I appreciate this opportunity to be with you. Again, remember, I just got done giving the bookends of my career. My first talk was to MPHA, and this is my most recent talk, it's to MPHA. So that's a wonderful bookends for me.
Well, we would love to have you back again many, many times, I'm sure.
Thank you. Thanks a lot.
If folks want to engage more with MPHA, some really good ways to do that are to follow us on social media. We're on LinkedIn, Twitter, Facebook, and Instagram. We also have our annual conference coming up September 15th and 16th, which will be virtually held from 11 to 3, so kind of that nice middle of the day. And that registration is open online. I encourage you all to register. And that's also a good place to look for other information about upcoming MPHA events is on our website. If you have any questions about anything MPHA, feel free to reach out to the membership committee. Our email is right there on the website, or on the slide. We're happy to answer questions, connect you with other members, anything like that. All right. With that being said, there's a lot of thank yous for you in the chat. I hope everybody has a wonderful rest of the day.
Bye. Thank you.
Bye. Thanks.